Good morning, everybody. Are you ready? Look at those words. MDS Payment Quality Survey. How many of you have some interest in one of those words? How many of you have an interest in all those words? You're the ones who really want, yeah, you're going to get a lot out of this. Look at them. MDS Payment Quality Survey. That's our world. That's a big part of our world. Well, we're going to talk about it, folks. We're going to have some real good learning here today. There was one piece of documentation that some of you might not have gotten, and we're going to distribute some of those to you. And if there's not enough, share it. Okay, if you got members from your team, multiple members, you guys can share. You share frequently. The PowerPoint presentation is in your manual or in your little handout. Beautifully done. I think that PharMerica probably puts together some of the best organized and most appropriate educational conferences in the country. And this is just another demonstration of it. But we are going to get rolling here. In your tab number 1, you have 3 documents. Okay, you have the PowerPoint. Everybody should have that open. Come on, let's get going here. You've had your breakfast, and so we're going to get looking. Okay, after the PowerPoint, you have a little handout with supplemental materials. Okay, all right. And what is in that? Do any of you recognize what those supplemental materials are? What are they? Nope. They're regulatory tags. Ah, about assessment. Yeah. Yeah. We're going to go through just a few quotes out of there, and I'm so glad PharMerica gave you highlighters. Get those highlighters out of your purse. Don't save them for the kids. They're to be used. No highlighters? Well, then get your pens out and you're going to circle things, okay? Then after that, very short supplemental materials, then you have PDPM information. How many of you have interest in PDPM? Only 15. The rest of you don't care whether you get paid? It's rolling down the track right now like an enormous steam engine. You are 4 months, 2 weeks out. And if you haven't started to prepare, you're about 6 weeks late. Yeah, 6 weeks late. So we're going to talk about the high points of that. And the materials that I'm giving you in this PDPM handout are directly from CMS. And you can go to the PDPM website under cms.gov, and you can download these very materials for your team. And our interdisciplinary teams need to understand this material. Now, we're going to move fairly quickly. We only have an hour and a half, and we're going to move fairly quickly. Some of you are going to feel like it's like drinking out of a fire hose, but that's okay. We can do it. You've done it before. There's a lot of important information here that you need to listen to, highlight in your materials, and then bring back to your teams. Now, how many administrators do we have here? Administrators? Oh, great. DONs? Ah, my favorite group, MDS nurses. Come on, raise them up high. Let me see. Ah, yes. Social service? Social workers? Okay. What about dietitians? Therapy? All those people I just mentioned need to know about PDPM, folks. This isn't going to be assign it to the MDS manager and hope it turns out okay, which happened a lot with PPS. It's a different way of thinking. So let's get right into it here. And we're going to talk about the importance of DBQ. Underline it. DBQ. Database quality. 100%, well, 99.9% of the information that is going to pay your bills under PDPM is going to be coded on the MDS. There is only one item that is going to be part of that payment process to pay your bills, only one item that will come directly off the claim and not off of the MDS, and that's the HIV/AIDS diagnosis. Everything else will come off of the October 1, 2019 data set, which has 18 more items on it than the data set that I gave you, which is the data set that your building is filling out today, the tricolored MDS. Now that is the best learning tool you can have to work with this transition. And administrators, please don't be penny wise and pound foolish in the world today. Get good learning tools into your building, and that's one of the best ones, because those green codes on there tell us all the items that are going to build payment. Okay? Very important. But database quality, what is that? Well, the first thing we have to look at that is that this is completely regulated. Database process is not involved with clinical standards from the American Geriatric Society. Database quality on the MDS is completely regulated, written, and monitored by CMS. We have an REI manual. We have directions in the survey process. Let's go to those right now. Go to that supplemental materials tab in your book, okay? Come on, go to the supplemental materials, and on the top of the page it says 636. 636 is on the top of that, as you all know, the old 272. Tag number 272 in the survey process directed the assessment process, right? Now we have a new tag, 636, all right? And it says, and if you want to underline some words, that you have to do a comprehensive, accurate, standardized, reproducible assessment of the elder's functional capacity, not their nursing condition. The MDS is an interdisciplinary functional assessment that contains clinical information. Very important now. When they say it has to be accurate, the word accurate you need to circle, because that means that everything you code on there has to come from the directions in the REI manual. Not what somebody learned in college, not what they've learned working as a social worker for 25 years at the hospital, not what somebody told them that they should do. They have to do it directed by the REI manual. Now, I'm going to read you, I have one page here out of the final rule, okay, which just was published 2 weeks ago, all right? It's out for comment, but it essentially is not going to change, all right? And this is what CMS says about your MDS data when we talk about database quality. It says, the new payment system uses clinical data from the MDS to assign case mix classifiers to each patient that will be used to classify and create their per diem payment. Okay, we all have heard this before. Okay, so then about 3 lines down it says, further, because the MDS is used as a basis for payment, which it is today too, but now we have hundreds of items on the MDS that are going to contribute to payment, not days and minutes of therapy and ADLs. In fact, days and minutes of therapy are not even going to impact payment. Okay? All right. Okay, so it says, as well as clinical assessment, we have provided, here it is, extensive training on proper coding and timeframes for the MDS completion in the RAI manual. For an MDS to be considered valid, now this is a new issue. CMS has a totally new issue now. They are going to decide when you send your MDS in if they consider it valid. They're not going to accept all the MDSs like the majority of them that they do now. Now you don't have your MDSs validated if they have egregious errors in them. Like no social security number. Like, you know, no name that connects to the social security system. To be considered valid, we've got new criteria. For use in determining payment, the MDS must be completed in compliance with the instructions in the manual in effect at the time of the assessment is completed. The manual contains manual instructions, coding instructions, and interpretive guidance of the federal rules and policy clarifications to appropriately create the data necessary for payment. We've never had this before. It's in the rule. So, most of these considerations have been part of the MDS process, but have never been in the final rule. So this is where we start. This is the first bullet point. The regulatory requirements for the facility database. That's what they're talking about here. So, go past, in your handout, go past 636, okay, which is a couple of pages long, and go to 641. Okay, ready? On 641, administrators, this is where you really need to listen to this part of the regulatory tags, because the surveyors know this is important. If you don't think surveyors are being trained on PDPM and the quality of data that we need, they are. On that page where it says 641 on the top, go to the third paragraph. Get your pens out. This is new regulatory information. Facilities are responsible for ensuring that all participants in the assessment process have, keywords, the requisite knowledge to complete an accurate assessment. According to the RAI manual, that is in effect on the day the assessment is created. So I meet people all the time. Thousands of people sometimes in a week. And I meet people who come up to me and say, I've been an MDS coordinator for 15 years. And I'll say, you know what? Congratulations, you've lived through a lot. But I don't want to know what you know in the last 15 years. I want to know what you know since October 1st of last year, when we had 190 pages of additional information in the RAI manual. So if you don't know that, I don't give a hoot if you've been an MDS manager for 15 years. Because what? You can't rest on your laurels in this system. The one thing an MDS manager needs to be is nimble. Or you're coding the wrong stuff. And I will tell you, as an expert on the PDPM system, and I am an expert, I have spent 24-hour periods working with people to sort out all this information they're putting out. Folks, if you don't get your MDSs right according to the coding and their directions, you will probably not be paid. We have this issue right now called RTP. Write it in the margin. RTP, return to provider. That means it's not acceptable. It won't go into the system. So we're playing with new rules. That's why I gave you, somebody came up to me outside and said, why are you giving us the current MDS? Because 78% of the data that you need for PDPM is on that colored document we gave you today. 78% of it you're doing in your facility, in your MDS process today. So now we have in the tags that everybody who works with the MDS has to have the requisite knowledge. Yet to be defined requisite knowledge by CMS. The implication is there. And then we go over to the next page with tag number 262, or 642, I'm sorry, 642. And remember that a registered nurse must, that's a very important word, either conduct or coordinate. You can't have blank or disconnected signatures of nurses any longer who don't know anything about how the MDS system works in your building. You know, you can't go to the mall and find an RN and have her sign your MDSs. Or take that RN who works the night shift and give her a whole stack and tell her to sign them while she's here. Because the person who signs the MDS, go on your colored MDS document that we gave you. Everybody got one? Okay, go to the back, go to the very back page, go inside the back page to the authorization signature. Who either conducted or coordinated the assessment? Conducted or coordinated is the terminology out of tag number 262. And then below it, it says, each individual who completes a portion of the MDS must sign and certify the accuracy of that portion. And that's what goes here. And MDS managers, administrators, go look at some of these. If you only have one person's signature here that they did the whole thing, I guarantee you it's wrong. I guarantee it. I'm out auditing probably 35% of the time I'm on the road. And if I see one person's signature that they're claiming that they did every piece of information on that form, I might as well delete it. It's impossible. Unless the resident comes in and dies the next day. But if you've got an assessment reference period that you're reporting on and you say that one person has integrated and observed and documented all of that information according to the REI manual, folks, a robot can't do it. So that's where we're talking about these words. Database quality. So first we have the regulatory requirements. And then we form the primary database for many purposes. Go to the front of your MDS, very front. What's the blue stuff down at the bottom? What is it? What's on the bottom of the page in blue? Quality measures. Ah, yes, some of our favorite reports, Nursing Home Compare. Aged quality measures. You know, we have this movement in the country right now that everybody wants to make beer, you know. And we have all these beers and we go to breweries and it is kind of fun. And, but, you know, when I think of Nursing Home Compare, I think of beer because they're aged quality measures. That's not what's going on in your building today. That's your level of falls 6, 8, 10 months ago. But yet it's on the public database. And the family that wants to bring someone to your building doesn't want to bring mom someplace where you have a lot of skin problems, pain, and people are falling all the time. Right? Those are the ones they look at. Then we have nursing home. Then we have 5-star. Yeah, let's hear it for 5-star. They just knocked us right in the gut on April 24th, didn't they? Any of you lost stars? You're not alone. We have about 7% of the buildings in the country that gain stars. That sounds a little bit harsh. 5-star. very, very sensitive database, point-based. And everything in 5-star quality comes off your MDSs. Interesting. What's the quality of the database? That's their standard. And then we have CASPR. CASPR is what? Your self-created quality measures. You go into CASPR and say, I want 30 days. I want 60 days, right? I want 90 days. I want to see what's changed since last month on our 90 days. Are we improving? You see the little color codes on here? They tell you which quality measures go into which database. Administrators, you need to know. And then the first thing you need to think about is who codes those indicators of depression? Who codes the pain interview? Who codes a fall with a major injury? You know, a lot of those codes are wrong. You know that? Because in the MDS, go to page 29 of your MDS. Go to page 29 of your MDS. Okay, there's where we record falls. I hope all the administrators here know that. This is the little grid. This is the part of the MDS where all that liability comes off, okay? It's very simple. Did the person fall? Whoops. Did they fall? It's yes or no. Ah, did they fall more than once? Oh, okay. See those blue boxes? That's what's triggering the fall quality measures. Okay, so when somebody falls, we have 3 opportunities to code what happened on the MDS. No injury, injury except major, and major injury. Now, in the world of medicine and nursing education and nursing practice, we use the terms, and I say that lovingly because I'm a nurse first, we do no injury, minor injury, major injury. I've been a nurse for over 50 years. I graduated from nursing school in the early 60s. All right? Yeah, calculate. I just had my 75th birthday. And I've always known what a minor injury is, right? When CMS wrote this form, they introduced a new term. What is it? Injury except major. That's the new term. I wonder how many errors there are in documentation. In your quality measures, because somebody didn't know the difference between a minor injury and injury except major. Injury except major is very big. An elder falls in the bathroom and cuts their forehead open on the vanity. They don't have other symptoms, but we send them to the emergency room for stitches, okay, and to be assessed. And they come back and they don't have a head injury, but they have their stitches. Is that a major injury? I hope you don't code it as, because it's not a major injury. It's a laceration without other symptoms, and what? It's an injury except major. But how is it written in your records? I'll tell you, after reviewing thousands of claims, thousands of records over the years, when they put this out, why aren't these definitions on your incident report? They should be. The outcome of the fall, no injury, just the way they're printed here. Database accuracy, very important. So now we're going to use hundreds of items off the MDS for payment, okay? Data is going to be combined with claims information for a lot of our Medicare oversight processes. And if you go back to the front of the form and you look down in the lower right-hand corner down there, we have the claims-based measures, and there are little purple diamonds down there. Do you see them? And then you look through the MDS, you will see those purple diamonds everywhere. There are 176 of them. Those are covariates that impact your readmission rates. And if you haven't looked at those and you don't understand those, you need to understand those. There's documentation on the CMS website for the claims-based measures that you have to read. Because CMS understands that elders, especially at advanced age with lots of comorbidities, who are in skilled nursing environments for long periods of time, frequently have to go back to the hospital because the SNF can't provide them the level of service or diagnostics or adjustments, whatever. Those covariates save you, if they're coded properly, they save you from unnecessary readmission statistics. So this database is very, very intricate. So the number of uses for the data is growing, and the number of uses for data in the payment process is literally exploding today. Exploding. 129 nursing items. 33 items on here that impact speech level of payment alone. 50 items that are like a gold mine for you with moderate acuity elders called non-therapy ancillaries, which we have never had payment tracks for before. So it's complicated. And you have to start with an accurate, appropriate, compliant database. DBQ, database quality. So what I say about the current database, and I live in it, is that a high percentage of ADL scores are wrong today. You've been trying to get those right for 20 years. Now you're going to have a much more complex functional performance scale score coming off of section GG. The person selecting the item response is responsible for the accuracy, therefore they should have all the coding instructions out of the current manual, updated. And they have to sign for accuracy. Administrators, please don't ever have one of your, unless you have in-house therapy, if you have contract therapy, your nurse or an in-house person should never sign for therapy minutes and therapy days, ever. Because they're not there seeing how they're coded. And I don't care what your contractor says, and I have plenty of business cards here, and if you want me to call them and tell them that that's the truth, if they won't listen to you, I will be glad to. How can an MDS nurse know what happened in the therapy room 2 weeks ago was coded accurately? It's impossible. And your building is billing $800,000 a month to Part A Medicare on the basis of those days and minutes. And nurses, if you sign it, it's on your license. And there are people in jail. Pretty strong stuff. So how does it connect to payment? Well, now the MDS formulates the payment rug. It's very simple. We get an ADL score. We look at the days and of therapy and the minutes of therapy, and we have a very simple equation. It's on the back of this MDS document, right up on the top here. You know, if you want ultra high, you got to have this, you got to have that, you got to have 720, blah, 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 right? All of that is going away. All of it. You can look at the back here because here are all the nursing criteria that are going to enrich your payment under PDPM, starting with extensive services. And all of these items are right for the future. One of the things that CMS understands very, very well is that a lot of your MDS information is wrong. That's why the RAC auditors are so successful. billions of dollars. They're not taking back millions. They're taking back billions annually because MDSs are not right. The data in your records don't match the MDS. And I get called a lot of times by owners who say, oh my gosh, we've got a rack auditor in here, and I own 9 buildings, and he's going to go to the 2nd building, and then the 3rd, and then they've already told us they're going to audit all our buildings. What can you do for us? Well, I can pray for you. I could send a letter to you and say, this is Leah Klusch, a nationally known consultant and compliance expert, and I really like Mr. Smith, the guy that owns the company. He seems like an okay guy, which is not going to be worth the paper it's printed on. But how do your records stack up? I met a social worker not too long ago, and I couldn't wait to get to this building because I looked at their CASPER reports and their quality measures and their 5-star, and they had no indicators of depression in their building at all. And they were 80% Medicaid, 20% short-term rehab. I couldn't wait to get there. I was going to walk into a building where everyone was laughing and smiling, where there were butterflies. Residents were walking down the hallway singing, oh, what a beautiful morning. It wasn't that way. It was a regular old 100-bed facility with 80% Medicaid. Forcibly having people age in a place that was not kind to their aging. I'm part of the force behind an organization called the International Council for Active Aging. When I get to be 90, I want to be their poster child. I've already signed up. Because last year at their meeting, I met a gentleman who at the age of 100 ran a marathon with his 2 72 and 74-year-old sons. I'm not there yet. So what's the difference between their routine and the 100-year-old gentleman who's been relegated to a wheelchair for the last 5 years? So anyhow, I went in this building and I met the social worker and I said, you know, I observe somewhat of a discrepancy between what your quality measures say and what's going on behind closed doors. She said, well, you know what? I'm the only social worker here, and I'll tell you the truth. I don't do interviews because I don't have time. So she talks to the team and says, you know, do you see any signs or symptoms of depression with Mrs. Jones, Mr. Smith, blah, blah, blah. And she goes and fills in the MDS and never does the interview. Ouch. Oh, my God. I actually went in the bathroom and took a couple of deep breaths. I wasn't going to puke or anything, but I just didn't. I thought, oh, my goodness gracious. And the rules say comprehensive, accurate, standardized, reproducible assessment, and the manual says you must interview or do a staff observation of mood every time you do an assessment. Quality measures are used now about half as much as they're going to be used next year at this time. And if you don't get that idea about the quality measures, you don't understand what happened April 24th with 5-star. You've got to pay attention to your quality measures, and you've got to look back and see who gave us this number. Which cases? Were they coded right? Please. So, accuracy is assumed. The regulatory tags tell us, okay? We have an elaborate set of directions, the REI manual. I don't go to the gym a lot of times because I carry 2 REI manuals around the office every morning. Keep my pecs strong. a few hundred pages of specific directions that need to be disseminated to everybody who codes on an MDS. So if you don't have a copy of the 2018 October 1 manual in your building right now, you are running the risk that your coding is bad, and going toward PDPM, you could lose 40% of your Medicare payment just because of not being aware of how to get the coding right. And administrators, I believe if you want to really understand this, and we're going to get into it in a couple minutes here, you need a copy of the manual in your office to see where and how that data is being formulated. The big term is data formulation. Looking at what's going on with the elder and putting that into the assessment in a way that is accurate, comprehensive, and standardized. And then that last big word, which will come, that's the whammy next year after PDPM, reproducible. On admission MDSs, don't go back and say we're not allowed to have any RUAs. On an admission assessment, you should never have an RUA. Because what you're saying is we're providing 720 minutes of therapy, multiple therapies, to an individual that we do not have to touch to care for them on the unit. That's what you're saying to CMS, and they recognize that. There have been millions of dollars returned to CMS on RUAs. They've been counting them for your building since October of 2016. They know how many you've had. It's amazing. This particular building lost $36,000 a month with RUAs alone on admission. And it's a good building. So the impact of accurate data on your quality measures gives you the picture you need. Here's the list of the quality measures, okay? And of course, now we have the claims-based quality measures, which are down at the bottom here, which involve our discharge and our outcome information with rehospitalizations. So your team has to understand the data that creates the quality measures. That's why this tool is so important. Administrators, these are cheap. In June, we will have another one of these, but I say you get these now so people understand. Just look through and see where you see the blue boxes. Look at page 15. My favorite page of the MDS is page 15. Look at the color. And if these codes are wrong, your care plans are wrong, your quality measures are wrong, your rehospitalization rates are wrong. And today, your PPS payment can be wrong. Now, we're not getting rid of ADLs. We are supplementing ADLs in the new payment system with the information from section GG on admission and discharge for self-care and mobility. And we're creating a new functional performance scale, which will affect your rate component for PT, OT, and nursing. Those are three very important components of the payment process under PDPM. And how much money you get for those individual areas is very dependent on how those functional performance scales come out. And those are from what? 3 days of coding, the first 3 days of the stay, which will more than often involve weekend days. The quality of data that you're going to collect on the weekends for the MDS and for the functional performance scale is dramatic. And you can't go back and just create it. It's got the same rules that everything else does. So, in October, okay, of 2017, that's almost 2 years ago, okay, they sent out more updated information. There were 20 pages of updates okay? And one of the things you want to look at on this slide, if you're following the slides, is that Q300 interview, the coding instructions for the Q300 interview that your social workers are doing about the elders' expectations. Very, very important. Put a shudder through the legal world, okay? That is page 42 of your MDS. Page 42, Q300, the resident's overall expectation. Go into the current manual and look at the coding instructions for that one. I don't have time to read it to you, but you will be surprised when you read that if you don't record the elders' exact expression of their expectations, even if they're totally unrealistic, that you have impacted the elders' civil rights. The first time the terminology civil rights has ever appeared in the REI manual. If that is a case that would ever go to court, ever have a legal action involved with it, ever have hearings, I will tell you they can really chase you on that one. Did you realize that? Who's doing that interview? Are they sensitive to what the rules are for doing that interview? Or did somebody just give them this page and say, do this? Without instructions. Folks, you're not going to be able to survive with this system with not reading the instructions. So, from 40,000 feet, what does your database say? How many databases do you create? How is the database changing as your demographics, as your short-term rehab grows? Do we have a dialysis unit now? Do we admit more people with skin problems? Do we have interostomal therapy? Are we doing a lot of stroke rehab? Whatever. How is that's why we have this thing we call in the regulatory process called what? The facility assessment. It's very important. You need to look at your facility assessment and look at your statistics. That's how your database is going to change. And how do you utilize it? How are you looking at your database? So, you want to look at your quality measures. Everybody takes a picture of your building from 40,000 feet on the outside. Who's responsible for accuracy and compliance with federal rules? And I believe that everybody who codes on your MDS, that's why I gave you these few pages of the tags. I think you should give these federal tags to every employee in your building who creates a code. And you give them 2 copies of that documentation. This is the federal rule. This is the foundation they work from. You give them 2 copies. They keep one. They sign one that they read it, and you put it in their employment file as part of their what? Competency documentation. When you hire a new social worker, you hire a new nurse, you get a new MDS manager, are they reading the federal rules? Do they know the questions a surveyor may ask them? Why shouldn't they? Very important. Very important. So, we've got the tags here, 636, 641, 642. And remember, Section GG is not exempt from reproducible data. When you code anything on the MDS on Section GG, first of all, it has to be 3 days of assessment. And if you want proof of that, if you're still using therapy evals, that is unacceptable as of last October, completely. Go in your current manual, page GG9, write it down, GG9. And that is where CMS says very explicitly, an interdisciplinary team of clinical professionals does the assessment for GG. That can include the therapy eval. But if somebody in therapy says, oh, we'll just send the eval over, and Rehab Optima or Kasamba talks to Point Click Care or Matrix or whatever you use, and you just code it in there, and then you don't have to worry about it. That's wrong. It's completely against the rules. I was at a CMS meeting 2 weeks ago in Baltimore, and someone from CMS said, I cannot believe that the provider community is still asking us questions about using the therapy eval when we put it in the manual last October that they can't do that. That's CMS talking to a group of leadership people from the industry. I was sitting in the back of the room and I thought, cha-ching, absolutely. You're right. They're right. It's in the manual. This is one of the documentation forms that's out on the market that you can use. Just one. Briggs, this is MedPass. Briggs has one. But you have to have something in your record about the other time that the patient is not in the therapy room. Now, if the elder lives in the therapy room, you're fine. Got that? If they live there. They've got their little setup in the back of the room, you know, in the OT section where the bathroom is. Okay. That's the only time that the therapy information is going to completely fill out GG. And of course, therapy has caregivers there and therapists there 24 hours a day, every day, for the first 3 days. That's kind of a sick joke, reproducibility. And so then we look at GG and we look at the new areas, and of course we have the newest interview of the family or the elder, which is what? Prior level of function. You gotta have interview information here, when you talk to the elder, who you talk to. Look at the manual. And under self-care, they've expanded things, now showering and upper body, lower body dressing, putting on and off footwear. How do our frontline staff evaluate how the elder can do that? And under mobility, we talk about rolling over in bed, car transfers if the person's going home, walking 10 feet. Do your staff members know how far 10 feet is? I'm a farm girl. I measure feet by my stride. My stride is just about 3 feet. So that was 10 feet I just walked. Now, how far is that on the clinical site between the bed and the bathroom, or between, you know, the common places where an elder is moving? Can they walk that far? We had an item before last October on the MDS that said what? Does the resident walk? MDS managers, remember that one? Does the resident walk? And what did they do with that item? What happened last October with that item? Nobody knows. They took it off the MDS. They replaced it with, can they walk 10 feet? So if an elder can only walk 3 feet, do you code that they walk? No. Boy, this room's awfully quiet. Then we go to section I, which is the big kahuna. PDPM is based on 3 things: diagnosis, functional performance scale, and comorbidities. That's what PDPM is going to pay you on. So go to section I, and we want to look at page 24 of the MDS. And let's look at section I. So now we're coding the primary reason for admission, okay, which also is synonymous with admission primary diagnosis, okay? And now your code, when we get to October, your code for that admission primary is going to be, please write this word down, the gateway code. If the code you put in section I for admission primary, okay, is not acceptable to CMS, your MDS data will not enter the payment system. Period. It'll either be returned to you or you'll get a notification that it's not applicable. And that's going to happen in one day. That transformation is going to happen in one day. So far you've been doing groupings of diagnoses. Administrators, you should be looking at which groupings you're using right now, because those are the areas in ICD-10 that your staff have to be good at. But now we have, look at this carefully, we have item 14 on this page, don't we? And 14 is what? It doesn't fit above, right? Okay. On the MDS in the fall, we don't have a 14th code. Every Part A Medicare has to fit into the 13 codes. There's no variable. So admission primary has to fit into the 13 groups. Then the individual code, where we have 14 here, and then this is your 14th code, which CMS isn't even looking at right now. Now we're going to have a new item here that will be your gateway ICD-10 code for the processing of the claim. Oh, interesting how things change. So, who's doing your coding? What do they understand? Section J, we have this issue about major surgery, okay? And 100 days prior to admission, and on the new MDS, we're going to have a whole list of surgical procedures and surgical information that you're going to have to code that will supplement the ICD-10 coding. That's all brand new. Today, we have additional information in section M on how to code a pressure ulcer. You know, one of the things that we can look at on the MDS you got in front of you is on page 33. Page 33. By the way, administrators, you need to know who codes section M and what their clinical background is and how accurate, according to the MDS, their information is. You know, section M has like 8 pages, completely new pages of information that they put in last October. I hope somebody's read that and your records reflect that. But go to item G. Last October, before October of last year, unstageable, it used to say suspected deep tissue injury. How many of you remember that? Okay? So what's gone now? Suspected is gone. So somebody comes in with mushy heels. You have to decide if you have a deep tissue injury or you don't. And the liability is on the facility now. So to say suspected, I mean, that's clinical liberty. You know, well, we thought it was there. That's what it means. That's gone now, folks. And so is a lot of the other terminology that was a little bit questionable in section M, like moisture-associated skin damage, MASDs. Read that carefully. It's all rewritten. If the skin is broken, like on a skin fold, if the very inside of the skin is cracked, you have to call that a pressure ulcer. Read the manual. Has a lot to do with what's going to feed PDPM, I'm telling you. Drug regimen review, I don't have time today to go over this. This is enormous. Please read those directions. Have good communication. You are with, those of you that are customers of PharMerica, you're with one of the best pharmacies in the country. And you have people on the inside of that company that want to understand and help and work with you. Look at today. Look at what they're investing in your education in a number of different topics. So Please make sure that your materials are and your policies are good. Remember, this October, all of your self-report of non-compliance is going to be in a quality measure. And it will be published on your building after October for what you've done this year, from October 18 to October, or to September 30 of 19. I've given you a list of the new and revised items that are coming out on the new MDS document. By the way, it's available on the CMS website, okay? And I've given you the list of those in your handout so you can go back and look at them specifically. You will notice, how many of you are from swing bed? Anybody here from swing bed? Okay, if you have swing beds, you've got more changes than the SNFs do, okay? And here is a picture of what that section I looks like on the new MDS. Okay, do you see the ICD-10 code at the bottom? That is your gateway admission primary code that will determine whether your case will be, your claim will be processed or not. Okay? Now, one of the things I want to talk about now is I want you to go in your handout beyond the tags and to that next section, the patient-driven payment model charts. Now, the first thing you need to understand is that this information is all from CMS, the CMS website, okay? So you want to get on the PDPM website on CMS, just go to cms.gov, put PDPM in, it'll take you to their front page, and all of these materials, new instructional materials, some of the training is going on in Kansas City next week, and I'm sure some of those PowerPoints will be on there. And you need to be actively seeking this information. Don't just go to seminars. Download the stuff and work with your team. It is very, very important. We are literally throwing the baby out with the bathwater. On September 30th, PPS will be history, complete history as a payment system at 11:59 p.m. on September 30th of this year. And on the 1st of October, at midnight on the 1st of October, we will have an entirely different payment system. So what you know about PPS now is you're going to have to flush that out. And some of you, it's the only payment system you've ever known. You know, a lot of us that are still alive that were part of cost-based reimbursement back in the 70s and the early 80s, okay? And there were a few people in the room who were there. It was a wonderful time to be in long-term care because we got paid great. But some of you have only known PPS. So those days and minutes of therapy are gone. The implication of the ADL to affect the level of payment, to take it from 621 to 698, if the ADL went from a 10 to an 11, it's gone. Now we're working with hundreds of items that will formulate into 6 specific contributing dollar amounts to a daily rate, each one calculated differently. And everything you're going to use to calculate it comes off of that data set. So my advice is, the first thing you do is our data right? Do the people coding on our MDS know what the rules are? Remember what I read from the new rule? It says, we have given elaborate, extensive training on proper coding in the REI manual. For the MDS to be considered valid for use in determining payment, it must be completed in compliance with the instructions in the manual effective the day of the assessment. So PDPM now is, and if you look at the PDPM clinical categories here, okay, at the top on the, in your supplemental patient-driven payment model information, you see that these are the items that are going to be on section I. Those are the categories, okay? For PT and OT, okay, bottom of that page, you will see the PDPM categories that relate to PT and OT, and what they've done with them is they've collapsed them, they've compressed them into 4 basic diagnostic groupings. Now, make a note on this page. You have to have a legitimate, appropriate ICD-10 code in the grouping to get into the payment system. You're not going to use an ICD-10 for medical management. You have to have an ICD-10 code that fits underneath that. Or a joint replacement. You can't just do a summary joint replacement code. You have to have a specific code for that elder, okay? Then what they do, if you turn the page, is they combine for PT and OT. Remember, we're not coding minutes to CMS. They're not looking at minutes here. They're going to look at minutes on discharge as a summary. So how much PT or OT and how many times? Oh, but the Medicare rules still apply. So they have to have therapy in order to be getting skilled rehab. They have to have therapy 5 days a week. We want to code skilled nursing. It has to be what? 1 skilled intervention every day. Those rules didn't go away. Those are the rules in the Medicare Benefit Policy Manual, Chapter 8. But now, if you look at this, you'll see that each of these areas have a range of functional performance scales that comes off of GG, right? And in those ranges, and remember functional performance scales in those ranges, okay? The higher the score, the more what the elder is? Independent. The lower the score, the more dependent. Now, most of you probably know about what case mix indexing is, and this is, it's a multiplier, okay? And the higher the multiplier, the more money you get, okay? So if you look at major joint replacement and spinal surgery, and you look at the 4 groups, 0 to 5, 6 to 9, 10 to 23, 24, okay? And then you look at in that area, the highest case mix index for PT is for someone who is, what? 24. Independent. And the lowest, right, is for an elder who is what? Totally dependent. That's by design. So under OT, the highest 1.68 CMS is for what? Not for somebody who is totally independent, because if they're totally independent, they may not need OT. I was doing an audit down in Arlington, Virginia last week, and I had an amazing experience with a CODA who was working with this little lady, and when she brought her in, she just looked to me like an Italian mama. She was little, and she was very put together. She had her hair combed and her lipstick on. She was going to therapy, okay? Found out she'd broken her hip, and she was having some therapy. And she was very talkative, very alert, and she was delightful. And so she did PT, and she was afraid to walk On her what? New hip. So the biggest thing they were working with her on was not just strength, but fear. She was afraid it was going to break again. A lot of elders are. So she had quite a challenge with PT because they wanted to convince her, and they were very gentle. They were very kind. She was, she was really doing well. But they took her over to OT, and the OT set up a bedside stand in front of her, and she had this basket of clothespins. Those big clothespins. And she wanted her to do the open the clothespins and put them on a rod, okay? And the lady looked up at her and she said, "Why am I doing this? My hands are fine." She said, "Oh no, the doctor said you have to, you need to do this." And she looked up at her and she said, "I'm not doing this." Then I knew she was an Italian mama. Years past, I had a friend whose mother was in one of the nursing homes, local nursing homes, and her roommate was an Italian mama. And I was in visiting her mom, and the other lady said to the people, she said, "I don't eat of the food here. My son, Victorio, is going to bring him my food. This is not good food. This is overcooked." So this lady was challenging the CODA. I loved it. Because her hands were fine. Her upper body was moving well. She had coordination. She didn't have paralysis. So then she said, "You come back into my room and I'll show you my crocheting and it'll show you how my fingers work." I thought, good for you, Grandma. Good for you. I loved it. Made my day. So now look at those, go down and look under other orthopedic. They're variable. Under other orthopedic surgeries, okay, and other orthopedic conditions, if you're completely independent, you get what? A low CMI. But if you're in the middle of the scale, you get a much higher CMI. Do you see how that functional performance scale and what those codes are on GG make a dramatic difference in how this is going to happen? And we don't record. They're not going to look at, we record it, but they're not going to look at how much therapy the person's getting until they're discharged. So the initial rate setting has nothing to do with how many minutes of therapy they're getting during that week. Nothing to do with it. Now let me go to speech. Speech is really hybrid. Speech is an enormous contribution to the rate setting. There are speech-related comorbidities that have to be coded on the MDS in the diagnostic codes, in some of the treatment codes. And then we look at the bottom of the page if the person has an acute neurological condition, Parkinson's, big player. Do they have a speech-related comorbidity? Yes or no? And do they have cognitive impairment? Now get your pen out here. Get your pen out. Because when you see that word cognitive impairment, that means a score on the BIMS of 12 points or less. That's a pretty high BIMS score. CMS changed the rules. In October, they're changing the rules on what is a cognitive impairment. So who's doing the BIMS and when are they doing them and what is the accuracy of that measurement to the person's capability and function? It could mean $30 a day to you. Then we look at how many of those issues are present. Then we look to see if the elder has a mechanically altered diet or if they have a swallowing disorder, both of which are check marks on Section K of the MDS. And a mechanically altered diet in person-centered care could be the elder's request, not a diagnosis. And who codes, go to section K on your current MDS, page 30. Who creates the codes at the top of the page? That's where the swallowing disorder is going to come from. Not necessarily the speech notes. You see where we need interdisciplinary communication, a tremendous amount of it? Hey folks, you got to take down the silos. Everybody's participating in this. I was in a building not too long ago where the dietitian came in the building once a month. Well, that's no good. That's no good for the MDS process. Who's going to make those clinical decisions on Tuesday and Wednesday and Thursday and Saturday and next Monday and Tuesday when we're admitting people in all these areas? Who's going to calculate the non-scale body weight? You know that if a person has an amputation, you don't use scale weight on the MDS. Do you all know that? You have to adjust the scale weight. Page K7 in the manual. Because we're working with what? IBWs, BMIs. Do you know that the code, ICD-10 code for morbid obesity is not an acceptable code for payment under Part A Medicare after October of next year? Because it has to be morbid obesity with a certain body mass range. So you got to get that right. So then we look at those two things, and you look at how many of the column 1, how many of column 2 are present on the admission MDS, and then that gives you your case mix index for speech. Turn the page. If all of those things are present, you have a comorbidity, and you have an acute neurological condition, you have cognitive decline, okay, on the MDS, you have a mechanically soft or mechanically altered diet, you have a swallowing difficulty, you could have a case mix index of what? 4.19 times the base rate. But if you don't have the right check marks, what do you get? Well, if you don't have any of those check marks, and your ICD-10 codes are not good, okay, you could have 0.68, which is less than, they're only going to give you 2/3 of the base rate. So you could lose $100 a day. We'll turn the page to where it talks about nursing. Now the next two areas I'm going to talk about are the big kahuna. This is where we're going to look at how do you prepare. But go to the back of the MDS, the back of the MDS document. See why you need to have these in your building? And people can sit and you can lead them through understanding this. Go to the middle, or just below the middle of the first column here, where it says extensive services. And the nursing rugs, qualifiers, and splits. We have a depression split on some and a restorative split on some, okay? There's 129 pieces of data here that come off the MDS that give you the nursing rug category that's going to be used along with the functional performance scale and the depression split to give you your case mix index numbers. And when you look at those case mix index numbers, know that the dollars per day in the federal rate, and that is what we gave you in that one-page handout, okay, when you first came in. These are the updated new federal rates, okay? So look at nursing. Look at nursing. In urban, it's $106. In rural, it's $101 per day. times this case mix. So if you've got somebody who's in extensive services, has a trach or a vent, you could get 4.04, okay, times the, and that depends on their, on how many services they need. But if they have a vent and a trach, okay, then you get 4.04 times your nursing rate as one component of your rate setting. That's $400 and some for one component. I've calculated rates out on cases where people have not vents, but a lot of comorbidities at $850 a day. I'll tell you what, they're not short-term rehab cases. It's very interesting. They're people with numerous issues. So we look down and we see, go to the next page where we start with special care high, HE, okay, HE1, HE1 and 2, and you see the depression split, okay? If the person has indicators of depression, score in the mood score of what, 10 points or more, right? And they have a low functional score, which means that they are what? Physically dependent, okay? They have a CMI of 2.39 times the nursing rate. If they don't have depression indicators, we're not coding that mood severity score properly on, remember, on the admission assessment only. And you know that mood interview has a look-back period of how many days? 14. It includes the hospitalization. Read the manual. You can't tell me all these elders are coming out of the hospital dancing and singing, oh, what a beautiful morning. They all think they're going to what? Die. They do. In general, they're very fatalistic. They've been terribly sick. And in most hospitals around the country, guess what? Hospitals don't feed and water elders, do they? They bring the tray in, they put it on the table, and what do? They walk out. And if you can't get to your food, what happens about a half an hour later? What happens? They take it out. So they all say that in the emergency room, everybody who comes in is dehydrated and malnourished. That's baloney. Everybody we admit has a certain component of, unless their family has been there every single minute, a certain component of malnutrition and dehydration because they don't feed and water people. Folks, get into the technicalities and you can be very successful. Turn a couple of pages and then we come to the gold mine. One of the things you want to look at on that page where it says NTA, non-therapy ancillaries, and this has a tremendous amount to do with medications, with interventions, with diagnostic coding related to medication administration. We have a new high-cost payment permission, payment calculation, for items that have historically been identified as expensive and related to good outcomes, if they're managed properly. There are 50 items on this list, 50. And all of these items come off the MDS except the HIV/AIDS diagnosis, which is coded on the claim itself. And here we don't have CMIs yet. Here we have, for the most expensive and the higher acuity items, we have points. But we get to score all the points here for all the items that are on that MDS. So we're talking about having that MDS be what? Rich. True, honest, but rich. So we add up the points on non-therapy ancillaries, and some of you can do that on your fingers. And then you go to the second page here, and you look at the little CMI calculator on the bottom. And if you've got somebody that has a lot of systems failure and neurological problems and metabolic problems and all these things, chronic issues, cardiovascular issues, blood dyscrasias, look at your CMIs here and take a look at those rates. $95 on urban and $97 on rural. And you're going to multiply that. Oh, shoot, they don't have the numbers on here. Somebody didn't print the right thing here. But it goes up to 4.0. So you could have a contribution to your rate of $350 or $400 for this one section. You can go to the PDPM website and you can find all these. Somehow the wrong page got copied in here, but it's very important that you understand. So what do you do now? Looking at your data collection process. Has it been updated? Tag 641. Facilities are responsible for ensuring that all participants in the assessment process have the requisite knowledge. What's the requisite knowledge? Well, we have the MDS manual on our computer. That's great. Can people get to it quickly? And in most instances, they can't. Because you have to open, in some software systems, you have to open an MDS before you can get to the manual. You need to have the manual readily available. This is called efficiency and economy in doing business with CMS. The more efficient you are, being compliant with the rules, the more success you're going to have. This is a painful process. First of all, one of the things administrators and MDS managers and DONs, you're going to have to start planning now for the last week of September and the first week of October, because we know when you convert, what's going to happen? You have to redo the MDSs on everybody who is in your building over the 30th to the 1st of October date, because you can't bill beyond the 30th of September on PPS. You can't bill a penny. So if you want to be paid for the 1st of October through the 9th of October, when this person's going to go home, you've got to establish a PDPM rate with a new, and they're going to be using a conversion MDS. It'll be the IPA. Has all the payment items on it. So you're going to have to do double duty, and you're going to need extra staff. You're going to need to plan. You should be putting strategic information together now. They didn't change the tags. They didn't change the Medicare benefit policy manual, and CMS has said this over and over. So now you have to train your staff, your interdisciplinary team, and make sure they are competent. This is a very complex system. One of the things that I have been dealing with this is to convert your thought process that you're going to have $6 amounts when you calculate this that are going to add up to the rate. I did a calculation for a customer of mine of 25 current Medicare cases they had in the building, and they just sent me the 5-day MDSs. So I just went through and picked out all the items I could find, and we put them through the process, and their GG coding was obviously wrong, because it showed that almost everybody was almost independent, which was a shame, because they lost a lot of money. But anyhow, I got 25 totally different dollar and cent amount rates. You have an in-house billing program. How are your billers going to react to that? Now they bill probably 7 or 8 primary codes, RUC, RUA, BBB, blah, blah, blah. You know, look at your rugs distribution. And everything is in those one area. So they just know, they know those numbers by heart. Now every single claim is going to have the potential to have its own dollars and cents per day. Think about that. How are you going to manage that? How are you going to talk about it? How's your utilization review going to change? It's going to change dramatically. What's contributing to the rate? We have one new assessment called the IPA, the Interim Payment Adjustment Assessment. When do you use that? When we get the new manual in the next week or so, the new REI manual instructions for October, thank goodness they're getting them out early. We'll learn about all the details for an IPA. We don't know the details just yet. But CMS is expecting it's only going to be used less than 10% of the time. It's not going to be like, and how are we going to handle significant change in IPA? That's the one thing they have not told us about yet. That's going to be very interesting. So what do we do now? Well, the first thing you have to do is get off your chair. Get started. Identify the process for data collection and assessment formulation in your building. Administrators, who's on the team? Who's functioning well? Who's brand new and hasn't been trained? I have people call me, I have clients in 41 states. So I'm working with teams and with companies and with organizations all the time. And I have people call me and say, oh my gosh, we hired a new social worker and they're not going to train her until July when the free training comes out from the state. I'll tell you what, administrators, DONs, owners, I'll tell you what the truth is about that. You're going to lose so much money that you're going to start to invest in training in this process and make sure it's right. It has to be practical. It has to be right. It has to show them how to use the manual. The manual is the guide. Include the MDS process in orientation. You shouldn't have anybody working in your building that doesn't know that we do MDSs. It's not that nurse's job anymore. Formulating and putting it in the computer is still the MDS manager's job. And the MDS manager or the RN assessment coordinator still coordinates the process, but the team has so much more to do. What happens at the point of admission? Who sets the gateway code? And do you have a reference? Do you have an electronic reference that you can go to and put the code in that will tell you, yes, it's good, no, it's not good? You need that. It's very important. And then, operations needs to be aware of what's in the facility database. Is it even feasible? I told you about those quality measures. I read that quality measure, and I thought in a 100-bed building and nobody has depression? Who let that go? We have all these people. Our falls numbers are going up. Well, maybe somebody's miscoding. What about that new LPN who's working on the long-term unit, and maybe she's coding wrong for falls with major injury? Could happen. We have to be careful. So, how many of you learned something today? Nobody. Holly, I was a failure. How many of you learned something this morning? Oh, come on. Are you asleep at the wheel? You got one of the best teachers in the country working with you, and you're telling me you're not learning anything? If you want to get paid, you have to prepare. You can't let this just go on around you. Don't just read a listserv and say, oh, I checked the ANAC listserv. Don't just do that. Administrators, first question you ask your team, where are the REI manuals? Are they updated? Just have one in your office and a couple in the MDS office, and they will be so grateful to you, they'll kiss your feet. We have more buildings without right manuals today, and it burns me because you're all going to have the risk of losing all this money. Tell me one thing you learned, nice and loud. Shh, shh, shh. Listen.
About really having interdisciplinary collaborative reviews and making
interdisciplinary collaborative reviews. You have to have it. You're going to have 6 opportunities to create a rate on every Medicare case. And now the rumblings in Baltimore are what? Next April, they may add Medicare Advantage to this. What did you learn?
That there's a lot that I don't know.
A lot you don't know. Okay, go to the PDPM website, right? Pull these tools right off. They're all there. Pull a case. Pull a 5-day MDS on a Part A case and see how many of these things are documented. Oh, that's a little shaky. Try it out. You can calculate rates today, and you don't have to have a PhD or a CPA. You can use it with your common sense. Well, it has been a tremendous pleasure to be with you today. Has this been good? Thank you so much.